call upon the next speaker, Dr. Mohan Rajan. He's going to be talking about toric IOLs in irregular corneas.
Thank you, Navalkar, and thank you, AIOCMT3, for the wonderful opportunity. I'm going to talk to, these are my financial interests. I'm going to talk to you on toric IOLs and irregular corneas. I'll finish within time, otherwise Chitra will kill me. And yeah, keys to refractive cataract surgery, the 4 mantras: increase refractive accuracy, decrease complications, choose the best visual quality IOLs, exceed patient expectations. Post-cataract vision, residual astigmatism, you know how it is. And one of the major problem is the contrast loss and the quality of vision. And if you take the 0.75, if you take up to 1.5, it's about 30%. If you take 0.75 as a cutoff, it will be almost 50 to 60%. My toric IOL practice has gone up from about 25% to about 60% now, because my cutoff is about 0.75 now. So changing astigmatism treatment paradigm, spectacles, then AK, LRI, which is not working in the long term, then toric IOL is probably a long-term sustainable results you can get. How do you determine the axis in unusual wise? Topography for irregular corneas with normal thickness. Barrett's true K for eyes with altered Gould-Strand ratio. Altered Gould-Strand ratio means there is a difference between the anterior curvature and the posterior curvature of the cornea. As for example, keratoconus, post-LASIK, post-RK. So all these patients can have this altered Gould-Strand ratio, and you need to go for. These are the Jens, Graham Barrett, Warren Hill, Paul Koch, and all these people. And these are the measurements. Always validate, take 3 measurements. And this is the most common error which we are seeing, not the axial length, but the keratometry. Because the keratometry, if you're not having an ocular surface which is pristine, then you can go wrong in the keratometry. And if you go wrong in keratometry, everything can go awry. So that is, I think we should concentrate on the keratometry. It's very, very important again. Validate the measurement, account for the posterior corneal. I'm going to give you just about 7 or 8 case scenarios. Diagnosis: pterygium with immature cataract. See the topo and see the cylinder, 7.16 cylinder. And post-operative correction after this thing, you can see here. Don't just put a toric lens when you have a pterygium. The problem is the pterygium produces a lot of corneal order, higher order aberrations in the cornea, but also alters the axial length as well. Please understand that also. So you can go wrong so many ways if you don't take care of the pterygium. So what I did was, first step, do the pterygium excision and wait for about 2 months, minimum 2 months, and then sometimes even 3 months you can wait, stabilize the ocular surface, and then go in for a toric lens. So after this, because the cylinder came from 7 to about 2.5, then put a toric lens T6 in this particular case. You can see the dense corneal opacity. I had never expected to promise the patient more than 6/18 vision. But you can see the post-operative. Really fantastic. The toric IOLs really give you the much better results than what you can imagine. So I think we should go in for toric lens whenever it's possible. Again, a traumatic cataract, post-corneal tear repair. Totally screwed up cornea. You can see here sutures are done. You can see the screwed up what you call topography here. Obviously, you need to do a penetrating keratoplasty. And post-operatively, I did a suture adjustment also. You can see here suture adjustment, and the cylinder came down after that. Case 3, again, a keratoconus, which had 5 years back, and this lady developed an autoimmune disease, and she was on steroids. And you can see the corneal topography is fairly stable for almost 5 to 6 years. Then what I went is dense posterior subcapsular cataract because of steroid, you can see here. And you can see the, again, the cornea maps there, the topography there, you can see here. I put a Clarion Toric T9 IOL for this patient. You can see I'm using the Callisto, the markerless system. Whatever you are comfortable, whether it's Callisto or you mark the cornea, it doesn't matter at all. You can see the post-operative results really fantastic. Left eye, she was not very happy, so I went ahead and did an AK. Of course, there's another patient with a multifocal lens, but this is not. Just to show you the AK, what we do with the femto platform, it's much more predictable than the LRI, what you do manually. So for small cylinders up to about 0.5, 0.75, I'll do the AK as well, and the patient did very well. Keratoconus post intact with the immature cataract, 6.9, -3, -2 cylinder. I went ahead with the phaco with the toric lens. Again, another patient, case 5, dark with immature cataract. And you can see +2 with -3 cylinder. All these, okay, level on the cornea. The cornea is quite stable. You can correct the lens. As Ramurthy was telling, the presbyopia is a disease, but also the astigmatism is also a disease. So you need to address the astigmatism as well, address the presbyopia as well, depending on the case scenario, whatever you're dealing with. So this is a post-DALK phacotoric lens, and this is the routine. Only thing is you have to make sure, as you can see, I'm using a Callisto again, and you can see the post-operative result, minus 0.5 sphere with minus 0.5 cylinder. Patient is very happy. Post-PK with immature cataract. Again, I'm patient, post-PK with immature cataract. Again, a toric lens I'm putting in this patient, and you can see the post-operative result is really fantastic in this patient. Again, post-RK with immature cataract. Shivani was talking about it. So this is the patient, you can see here. Again, toric lens. These are all these toric lenses. They do pretty well. So I put a scleral incision, and this is only an 8 RK thing. So if it's more than 16 RK, 32 RK, then you need to be a little careful. Of course, I do femto for many of these patients. Of course, this is another patient, very tough scenario, PMD, pellucid marginal degeneration, 7.5 cylinder. I put a customized toric lens for this patient. You can see the post-operative surprise, 5 cylinders still, because that was probably, you can see how the topography is pre-operatively. And despite the toric lens, customized toric lens, still I had a 5 cylinder. Then I spoke to Amar and he said, why don't you do pinhole pupilloplasty? So pinhole pupilloplasty is something which is very good in these cases. So I did a pinhole pupilloplasty, brought the pupil to about 2 millimeter, and you can see that the patient did very well. The take-home message is very simple. Toric IOLs are very effective, even in uneven astigmatism. Always stabilize the cornea first and then go for the toric IOLs. Clarion toric is probably the best because of the wide range and also excellent rotational stability and fantastic long-term results as well. I don't have any financial interest. For patients who have very high astigmatism, go for either customized toric lens or combine that with astigmatic keratotomy or what is called bioptics, what Ramurthy was talking about as well. Goal is happy patients, results exceed expectations. Thank you, AIOS, for a wonderful opportunity. Please email to me at drmohanrajan@gmail.com for these books, Cornea Atlas and Retina Atlas. I'll send it by courier to you, and I need your blessings and support for my elections. Thank you very much, ladies and gentlemen, for the wonderful opportunity.
Thank you, sir, for that, giving us courage to try toric IOLs in some complicated corneas.
Absolutely, we can go ahead and it's very forgiving as well. The toric IOLs, if you put T8, T9, quite stable, and you can amazing results. You can't even imagine these results. Patients are so happy. Even if you correct, okay, out of 7 cylinder, if you correct 5 cylinder also, the patient will fall at your feet. Just like hyperopic, presbyopic patients, like what you have, Ramurthy. Yes.
Thank you.
I think excellent presentation, Mohan. I mean, one small tip I would give is whenever you're trying out these irregular corneas, whether it's keratoconus, scarred, please look at what the patient's visual acuity improvement with glasses. If the patient is improving with glasses, then that is an eye which can be good for toric eye, phakic IOLs or toric intraocular lenses. If the patient has irregularity, lot of higher order aberrations because of which requires a Roski or a semi-soft contact lens for rehabilitation, these patients do quite badly after a toric intraocular lens. Because the astigmatism on the cornea is irregular astigmatism which is picked up on refraction. So otherwise, if patient is happy with glasses, all that Mohan said is absolutely valid.